Hello, welcome to the East Practice Management Guidelines lecture series. My name is John Como. I'm going to talk about formulating robust PICO questions. So the guideline methodology that's been used by East since 2012 is called the Grading of Recommendations, Assessment, Development, and Evaluation. The acronym is GRADE. What GRADE requires is a clear specification of the relevant population, intervention, comparator, and outcomes, or PICO, which is the acronym. No matter which methodology is chosen, before 2012, East used the AHCPR methodology, but no matter which methodology is chosen, we will use GRADE from here on in. It's imperative that the clinical question be framed appropriately. And this PICO methodology is a well-accepted way of framing questions in systematic reviews and in guideline development. Here's a diagram which shows what we do. Basically, the first step is at the top. We create an East PMG team after deciding what our guideline is going to be about. Note that the first thing we do after that is we define what our PICO question is going to be. That's our first step. The way we used to do it was we review all the literature and then come up with ideas and recommendations based on just our general review. It wasn't very structured. This makes us define our questions first, and that's followed then by our review of the literature, meta-analysis and grade, evidence profile, recommendations, manuscript, and so forth. But PICO questions are generated very early on nowadays in this process. So we want to frame the question. We want to find answers to specific questions in the medical literature, and that's often a challenge. For example, which blunt trauma patient should receive splenic angioembolization? Now that's not framed in the way we want a question to be framed for our purposes. We'll go through how to do this in some detail in this short lecture. The methodology should carefully specify the patient population, the intervention of interest, the comparator, and the outcomes of interest. And it's very important that these all be very specific. This, again, is popularly known as the PICO principle, and it involves dissecting a question into its component parts to facilitate finding its answer, and it's an essential first step in evidence-based medicine. We want this PICO question to generate an answer which will be in the form of an action statement. And the question is divided into 4 parts. Okay. It involves carefully specifying P, the patient population, I, the intervention of interest, C, the comparator, and O, the outcomes of interest. Okay, so in the diagram, looking at this diagram, P stands for population, patient, or problem. Who are the patients? What is the problem? I stands for intervention or exposure. What do we do to the patients? What are they exposed to? C is for comparison. What are we comparing the intervention with? And O is for the outcomes. What happens and what is the outcome? What are the outcomes? So going back to P, the population. The P in PICO stands for the patient, population, or problem to whom the recommendations are meant to apply. So who are the relevant patients, or what is the problem? It's important to be in this as specific as possible, and we'll come back to this a little bit later. I is for intervention. It can be a therapeutic intervention, a diagnostic test, or in observational studies, an exposure. This could be a surgical procedure, a medication, other clinical therapies, some type of diagnostic test, screening for some type of disease, lifestyle changes such as diet and exercise, some type of exposure, or social activities such as drinking, drug use, tobacco use, and things like that. C is for comparator. It's an alternative intervention. It can be a treatment strategy, a test, an exposure, or an intervention done in the control group. Sometimes it's obvious, but when it's not, the comparator should be stated explicitly. For example, in this diagram, we could be comparing plan A to plan B, but we also could be comparing the plan A versus nothing, placebo. Sometimes it's obvious. If it's not obvious, we need to specify exactly what the comparator is. And O is for outcome, the outcome or outcomes of interest. What are the patient-relevant consequences of the intervention? A common error is not to include all the patient-important outcomes. So, for example, adverse effects, toxicity. What we generally do in our guidelines is we ask our guideline panel to think of every possible outcome that might be relevant. And then we vote on those outcomes, and we keep the critical and important outcomes, and the ones that are not deemed to be important, we don't worry about anymore. But in order that we get every possible outcome that might be important to our clinical question, we ask the team to start with every possible outcome, and we whittle them down later on. Sometimes you'll hear about timing and setting, what's called a PICO or PICOTS question. Most of the literature says that this is neither helpful nor necessary because they're all part of a well-defined and structured PICO question. So, for example, time, in other words, the duration of treatment or when outcomes should be assessed, is really covered by specifying, being very specific about the interventions and outcomes, such as 1-year mortality. All right, so that should be specified as part of the outcome. The other is setting. So, for example, certain recommendations may be different based on if you're in a resource-rich setting or a resource-poor setting. Okay. However, this should be covered by the population. So, if it's a question about patients in, say, sub-Saharan Africa, that should be defined as part of the population in the PICO question. The most challenging decision in framing the question is how broadly the patients and intervention should be defined. So on what basis should systematic review authors or guideline developers make this decision? Well, it's important that across the range of patients and interventions, it must be plausible that the effect, the magnitude of effect on the key outcomes is roughly the same. If this is not true, then the reviewer guideline will generate misleading estimates for at least some of the subpopulations of patients and interventions, because the effect will be different. So, for example, if antiplatelet agents differ in effectiveness in those with peripheral vascular disease versus those with a myocardial infarction, a single estimate across the range of patients and interventions would not be appropriate. Okay, the effects will be different. These populations should be defined separately, and really separate PICO questions should be generated. So one would be antiplatelet agents in patients with peripheral vascular disease. Another would be antiplatelet agents in patients with myocardial infarction. Recommendations may also differ across subgroups of patients at different baseline risk of an outcome, despite there being a single relative risk that applies to all of them. So, for example, looking at warfarin therapy, okay, it's associated with anticoagulant effect, but it also has the downside of having both risk of bleeding and also its inconvenience. However, it's much stronger in atrial fibrillation patients who have substantial risk of stroke versus minimal risk of stroke. And again, the solution here is to be very clear in your population. So, and you probably, if there is a different baseline risk of an outcome, to define different PICO questions. One would be in atrial fibrillation patients at substantial risk of stroke, another atrial fibrillation patients at minimum risk of stroke. Another important challenge occurs when there are multiple comparators to an intervention. It's very important to be clear in the choice of your comparator because it makes for an interpretable guideline, and a lack of clarity can create confusion. Again, sometimes the comparator is obvious, but when it's not, guideline panels should specify the comparator explicitly. In particular, when multiple agents are involved, they should specify whether the recommendation is suggesting that all agents are equally recommended or that some agents are recommended over others. So again, the idea of A versus B versus A versus placebo, for example. So how do we frame the question? Okay, here's an example PICO question. In stable acute blood trauma patients with splenic contrast blush noted on CT of the abdomen, P, should angial embolization be performed? That's the intervention, or I, versus observation without embolization, C, to improve splenic salvage. And if I had to critique this question, I'd say we need more outcomes than we have here. But otherwise, the population is specific, the intervention is clear, and the comparator group is also clear. If formulated properly, the PICO question will generate an answer in the form of an action statement. An ideal key action statement describes who may, should, or must do what, to whom, under what circumstances, how, and why. They are prescriptions of a specific behavior of a provider, and they should be unambiguous and precise, should not be vague or underspecified, and should not be statements of fact. So some examples of action statements. These are actual EAST guidelines. 1, an admission EKG should be performed on all patients in whom blunt cardiac injury is suspected. That's an action statement that tells the provider what that provider should do. Or, a single preoperative dose of prophylactic antibiotics with broad spectrum coverage should be administered to all patients sustaining penetrating abdominal wounds. Another action statement that tells the provider what the provider should do. The following are examples of what are non-action statements, and these are actually statements that have been in prior EAST practice management guidelines. So we want to avoid things like this. For example, computed tomography with axial collimation is superior to plain films in screening for thoracolumbar spine fractures. Now that may be true, but it's not a recommendation. It's a statement of fact. Another that we've seen in one of our prior guidelines is that mild traumatic brain injury is defined as an acute alteration in brain function caused by an external force and is by a blunt external force and is characterized by a Glasgow Coma Scale score of 13 to 15, loss of consciousness less than or equal to 30 minutes, and duration of post-traumatic amnesia of 24 hours. That's a definition. That's not an action statement. So we want to avoid statements like this. So going back to the PICO question we had talked about before, the PICO question states, in stable adult patients with blunt splenic trauma with contrast blush noted on CT of the abdomen, should angioembolization of the spleen be performed versus observation without embolization to improve splenic salvage? This question generates an action statement. So, in stable adult patients with blunt splenic trauma with contrast blush noted on CT of the abdomen, angioembolization of the spleen should be performed versus observation without embolization to improve splenic salvage. That PICO question leads into an action statement that is thus generated. Sensible recommendations will require consideration of all outcomes that are important to patients, as I mentioned before. They may also require consideration of outcomes that are important to others, including resources paid by third parties, the impacts on those who care for patients, and public health impacts. And if evidence is lacking for an important outcome, this should be acknowledged rather than ignoring the outcome. We must predefine, as I said before, which outcomes are important. The outcomes are generally, again, all possible outcomes are put forth to the group, and the outcomes are voted on. They're either limited importance, which is a value of 1 to 3, important outcomes, which are a value of 4 to 6, and critical outcomes, which are a value of 7 to 9. So for blunt splenic injuries, it was deemed that critical outcomes were mortality, splenic salvage, and need for further transfusions. Important outcomes had a value of 4 to 6. Important outcomes were contrast allergy, contrast-induced nephropathy, and arterial access complications. And one that was thought to be of limited importance was cost and resource use. So we define which outcomes are important before we start our literature search. Once the questions have been framed and important outcomes have been decided, we then perform our systematic review of published literature, including all relevant studies for each question. We then rate the quality of evidence and make a decision about the strength and direction of recommendations. These will be the subjects of further videos by our group. So in conclusion, GRADE requires a clear specification of the relevant population, intervention, comparators, and outcomes, or PICO. Outcomes of interest should be those important to patients, and they must be clearly specified. An initial rating of the importance of outcomes should precede a review of the evidence, and this rating should be confirmed or revised following the evidence review. I'd like to thank everyone for listening to our video series, and thank you for your attention.